is anemia in children, and this has to be the first topic. This is like an entry topic regarding hematology. Now, to start with, let's talk about the definition. What is the definition of anemia? See here, anemia is defined as a reduction of the red blood cell volume or hemoglobin concentration below the range of values occurring in healthy person. Anemia is defined as a reduction of the red blood cell volume, or even number can be added there. If red blood cells are decreased in number, it is also known as anemia. Or very commonly used in the clinical practice is the hemoglobin concentration. If it falls below the range of values which occur in healthy person, we call it anemia. So you can simply say anemia is when hemoglobin concentration decreases than the normal range, or when RBC number falls below the normal range, it is anemia. Now, to add to your definition, you must remember this. These are the cutoff values for anemia given by WHO, World Health Organization. Now, please pay attention. You have to remember this. In children between 6 months to 6 years, okay, between 6 months to 6 years, the hemoglobin, okay, the lowest level of hemoglobin is 11 gram. That means if it is less than 11 gram, we call it anemia. Normal value is more than 11. That's why it is known as cutoff value. You understand like this, okay? In older children, 12 gram per deciliter is the lower limit. Less than this, we call it anemia. So normal value is more than that. In adult woman, in pregnant, we call it 11, and non-pregnant 12. Now, one small question, you have already done this before. Why in pregnancy the hemoglobin is lesser than the non-pregnant state? Why?
Because of hyperdynamic condition.
Okay. Yes. Some more student, please. Anybody want to say here?
Because plasma volume increase. Because the blood volume increase, sir.
Okay. So there are different reasons. Different reasons because blood volume increases. Okay, so RBC concentration falls in comparison to the increase in plasma volume, and pregnancy is a hypermetabolic state. Hypermetabolic state. So it is a slightly deficient state, I can say that. Okay, and it is a slightly iron deficient state also. That's why in case of pregnancy, remember, we always supplement iron, always give iron, so that they don't develop a typical iron deficiency anemia. So in case of pregnancy, because of this multiple reason, the hemoglobin level is slightly lesser. Adult male, 13 gram. So it should be more than 13 to be normal. Less than 13 is anemia. Now, this is the WHO grading of anemia. Now, according to that, we have 3 types: mild, moderate, and severe grade. Mild anemia means from 10 gram per deciliter to cutoff point for the age. Okay, cutoff point for the age. If I talk about adult male, the cutoff value is 13. So from 10 to 13 is the mild anemia. If I talk about non-pregnant woman, 10 to 12. If I talk about children, 10 to 11. So it is very easy to remember like that. Moderate anemia from 7 gram to 10, and severe is less than 7. So this is a very useful type of classification. Severe anemia means when hemoglobin level is less than 7 gram per deciliter according to WHO. Now, for a clinician like us, we have the clinical grading of anemia as well. When we examine the patient, we can grade anemia from the examination finding. Now, what is mild anemia according to the clinical examination? That means when the pallor is restricted itself to only the conjunctiva and or mucous membrane, we call it mild anemia. Now, how to examine pallor? Probably, it is difficult to show you, okay, from this type of teaching, but if there is any opportunity for us, when like in near future, we'll definitely go to our university. We will conduct some practical classes for you and definitely show or demonstrate how to examine the patient. Okay, so right now, just listen properly here. Pallor is examined in different areas. The first is palpebral conjunctiva. So let me write that here. Palpebral conjunctiva. What is palpebral conjunctiva? There are different types of conjunctiva. Conjunctiva is the mucous membrane which covers the front of the eyeball. So bulbar conjunctiva and palpebral conjunctiva are the main type. Now bulbar means right at the center of the eyeball. If that conjunctiva, okay, we call it bulbar, and below the lid we call it palpebral conjunctiva. Below the lid. So what I do, I will retract the lower eyelid of the patient, ask the patient to look upward and look how pale is it there in the palpebral conjunctiva region. If it is pale there, this patient is anemic. That is the meaning. Another is, ask the person to stick out the tongue. Look how pale is the tongue. This is another type of mucous membrane. Now, another site where we examine pallor is the palm. Okay, palm. If palm is very, pale, then also it is anemia. And sometimes in severe anemia, the palmar creases are also not seen properly. The palmar creases are also not seen properly. This means it is a severe type of anemia. So this is mild, moderate, and severe. Let's move on. Now, let's go to one of the important part. What are the physiological consequences of anemia? What anemia is doing in our body? There is decreased oxygen carrying capacity of the blood if we develop anemia. So what is the function of our RBC? Everybody know that. What is the function of hemoglobin? Everybody know that. So anemia is all about decrease in either RBC number or hemoglobin concentration. So there is decreased oxygen carrying capacity. Now, what is the consequence of this? At the tissue level, there is hypoxia. Okay, at the tissue level, there is hypoxia, which is written here. There is decreased oxygen delivery to the tissue. Now, tissue at the same time try to increase oxygen extraction from there because of, okay, the compensation or compensatory mechanism, and that is helped by increased 2,3 DPG concentration within the RBC. Now, this 2,3 DPG is 2,3 diphosphoglycerate. Diphosphoglycerate. It is one of the product of HMP shunt inside the RBC. The function of this 2,3 DPG, it helps to unload the oxygen to the tissue. If we have increased 2,3 DPG level, it is good for the tissue. It will unload the oxygen. Okay. But if we have decreased level of 2,3 DPG, it doesn't unload the oxygen to the tissue. This is not a good situation. Higher levels of erythropoietins will be there in case of anemia. Now, how to explain this? Very easy. Just follow this. There is decreased oxygen delivery to the tissue, means there is tissue hypoxia. Kidney is one of the tissue. So when there is decreased oxygenation of the kidney, kidney will release erythropoietin. Okay? Erythropoietin will act on the bone marrow to form or to try to synthesize more RBC. This is also a type of compensatory mechanism. We are having anemia and our body is trying to synthesize more RBC, okay, to bring the situation back to the normal. There is increased workload to the heart. Very important point. So let me highlight this here. Increase workload to the heart. there is increased heart rate and cardiac output. Now, why is this? How to explain why there is increased workload to the heart? Anyone?
May I explain it, sir? May I explain it, sir?
Yes, sure.
Sir, basically, sir, this is a type of compensatory mechanism, sir. Because, sir, when we have anemia, sir, we have less blood supply to the white lung. Sir, this in case will force the heart to bring more workload and bring more cardiac output. So, sir, in the form of bringing more cardiac output, so the heart rate will increase. So, this is the main phenomenon. It is a compensatory mechanism, sir.
Very good. Very good. Excellent description. I'm sure many other students also know this. Very easy. Just like, any other tissues, the heart is also hypoxic because of decreased hemoglobin concentration or decreased number of RBC. Okay. So heart thinks all the tissues and organs in the body are hypoxic because of decreased blood flow. So heart is, thinking a bit different way. So to increase that cardiac output or blood pressure, heart is trying to pump faster and stronger, leading to increased heart rate and increased cardiac output. Now, heart can, do this for a shorter duration, but not, every time. So after some time, if anemia is not treated, heart will develop failure. So anemia is a cause of heart failure, okay, over a long period of time. Let's move on. Let's talk about what are the overall clinical manifestation of anemia. This is overall, okay? So how the anemic patient present or manifest. There are few symptoms and signs till hemoglobin level reaches 7 to 8 gram per deciliter. The symptom and signs are very few. Person may be a bit tired when they overwork. That's it. Pallor of skin and mucous membrane is a very important feature of anemia. That's why we examine this all the time. Palpebral conjunctiva, okay? Ask the person to stick out the tongue and examine that. Examine the palm. Okay. These are very important sites. The person becomes weak in case of anemia. This is called weakness because the muscles are getting hypoxia, okay? So the muscle cannot function properly, resulting in weakness or easy tiredness, you can say. Tachypnea or increased respiratory rate may be there. Shortness of breath and exhaustion, very important feature of anemia. Anemic people will behave like that. They cannot run faster like the normal person. They cannot go to the mountaineering like a normal person. They cannot even go to the gym and do exercise like other normal person. They become breathless. Tachycardia and palpitation. You can add palpitation also here. Cardiac dilatation, because chronic anemia is hyperdynamic circulation, and hyperdynamic circulation will lead to dilated heart over a period of time. This is the way we explain here, and definitely it is one of the cause of congestive heart failure. Now, this is a normal blood film. Okay, simply, we have already done this before. See here, this is how this WBC looks like, and these are the different RBCs. These are the clumps of the platelet. Okay. Now, let's go to the main part of this particular lecture, how to classify anemia. How we do that? There are different ways by which we classify anemia. So let's talk about each of them. So this is the classification of anemia according to underlying mechanism. So I'll go very slowly here. The one mechanism is blood loss. Another, increased rate of destruction, which is known as hemolytic anemia or hemolysis. And third is impaired red cell production from the bone marrow. These are the three important mechanisms. According to the blood loss, we have got two types, acute and the chronic. Acute blood loss occurs in severe type of trauma or surgery, okay, in case of certain obstetrics and gynecological conditions. we may have acute blood loss. Now, different example I can provide you here. Femur fracture, pelvic bone fracture, or any serious type of compound fracture or open fracture. Spleen rupture, liver rupture, rupture of aortic aneurysm or any other big aortic or artery aneurysm. In case of female, ectopic pregnancy rupture. So all these are different, causes of acute hemorrhage. In case of acute blood loss, there is always anemia development, but it may take few hours. It is not a, instant type of anemia development. It always takes few hours for the hemodilution to occur, and then only anemia occurs. Now, a type of anemia which is seen in case of acute blood loss is known as normocytic, okay, normocytic normochromic anemia. Never forget this. This is a very important MCQ question which is asked in the exam. Normocytic normochromic anemia occurs in acute bleeding. Whereas in chronic bleeding, we have microcytic hypochromic anemia. Now, the question must be coming in your mind. Why so? Why in chronic bleeding there is microcytic hypochromic anemia? And the answer is it is associated with iron loss from the body. And when there is iron deficiency anemia, it is microcytic hypochromic in nature. Okay. Now, the common causes of chronic blood loss are lesions of our gastrointestinal tract, different cancers of the GI tract, especially right-sided colon cancer in very old person. And there is a peptic ulcer disease or gastritis, which also leads to, a bit of blood loss in the stool. And one important example I want to highlight here is a hookworm infestation. Hookworm is a type of parasite which keep on sucking the blood. And that is an important cause of a microcytic hypochromic anemia from the GI tract. In female, gynecological disturbances, very common cause of anemia in female. When they start to bleed or menstruate, if the history is a menorrhagia, excessive blood loss during every period, these female, they got quite weak at the time because of anemia, because they are losing a lot of blood. So this is also iron deficiency anemia. Let's move on. Another important mechanism is increased rate of destruction or hemolysis. Now we are dividing that into two parts, intrinsic and extrinsic abnormalities of the RBC. We'll talk about this a bit later, okay, when we enter into the hemolytic classification in detail. The third one is impaired red cell production from the bone marrow. Bone marrow is the site where RBCs are formed. If something wrong occurs in the bone marrow, RBCs are not going to form properly, leading to anemia. Now, what is that? Hemolytic anemia. What are the types? Hemolytic anemia is caused by increased rate of destruction. Synthesis is also going on, but destruction is faster than the synthesis, or destruction is at a more rapid level or increased level than synthesis, then only hemolysis or hemolytic anemia occurs. Now, let's talk one after other. The first type of hemolytic anemia is because of intrinsic or intracorpuscular abnormalities of red cell. Means inside the red cell, there is a problem. It can be hereditary or acquired. Now, let's talk about hereditary first. Red cell membrane disorders like hereditary spherocytosis and hereditary elliptocytosis. These are important disorders, especially spherocytosis, hereditary spherocytosis. It runs in the family as autosomal dominant disorder. Autosomal dominant disorder. Now, what is the chance of having autosomal dominant disorder in every pregnancy? What is the chance?
25%.
50%.
It's 50. It's 50%, okay? It's 50. This is a dominant disorder, not a recessive one. If I ask recessive, then 25% would be the correct answer. But dominant disorder, there is a 50% chance in every pregnancy. So there is a very strong family history present there that you should remember. Now, another type is red cell enzyme deficiency. And as a result of this, we have hemolysis. And the important enzymes are glycolytic enzyme, like pyruvate kinase deficiency and hexokinase deficiency, and enzymes of HMP shunt. Okay, enzymes of HMP shunt, like G6PD deficiency and glutathione synthetase deficiency. They can also result in hemolysis. Now, among them, from the exam point of view, they love to ask G6PD deficiency. G6PD deficiency. Now, this G6PD, so, listen, I want to provide some information right here so that you have a clear picture. What is this all about? G6PD is the enzyme which is present inside the RBC. It is a byproduct of hexose monophosphate shunt, or I should say it is one of the enzyme of that, okay, in HMP shunt. Now, the function of this G6PD is it will keep the NADPH in the reduced state. It will keep NADPH in the reduced state. And that NADPH must be in the reduced state to neutralize the oxidative damage to the RBC. There are so many oxidative stress to the RBC. Some of them may be infection. Some of them may be drugs. Okay, some of them may be food. So what is the point here? To prevent from that oxidative damage of RBC, we need G6PD enzyme. If this G6PD, that is glucose 6-phosphate dehydrogenase enzyme, is absent, then those oxidative stress will severely damage the RBC, resulting in hemolysis. This is known as hemolytic anemia by G6PD deficiency. Okay, so this is a concept. And this is a big topic in itself. Okay, so we'll talk about this somewhere else. Another is disorders of hemoglobin synthesis. See here. Disorders of hemoglobin synthesis. Now we have two categories here. Deficient globin synthesis results in thalassemia syndrome, and structurally abnormal globin synthesis, which are known as hemoglobinopathies, results in sickle cell anemia or unstable hemoglobin, like hemoglobin C and hemoglobin E. Now let me clarify this. Thalassemia syndrome, or simply called thalassemia, are the disorders, okay, they are a genetic type of diseases where there is deficient globin chain synthesis. Deficient globin chain synthesis. We have got different types of globin chain according to the type of hemoglobin. In hemoglobin A, we have alpha and beta globin chain. In hemoglobin A2, we have alpha and delta. And hemoglobin F, we have alpha and gamma globin chain. So if those globin chains are deficient, then we suffer from thalassemia. This is a very, very common disease in Pakistan. Please remember this. Abnormal type of hemoglobins are synthesized. We call it hemoglobinopathy. One of the examples is sickle cell disease or sickle cell anemia, where we call it hemoglobin S. Whereas some other types of abnormal hemoglobin also exist, like a hemoglobin C and hemoglobin E. Let's move on. Now, another is acquired type of problem, acquired type of disorder. All those are hereditary, we just talked. Now, this is acquired type of disorders where there is intrinsic problem in the red cell, especially on the red cell membrane. And that is paroxysmal nocturnal hemoglobinuria, or PNH. PNH. Now, let me talk something about this PNH. This is acquired type of hemolytic disorder. That's the first thing. Okay. Now, what's the problem here? there is a protein, okay? We call it surface protein. In case of RBC membrane, that is known as decay accelerating factor, or also known as CD55, because the CD55 gene is, coding for that. When that protein is defective, when there is presence of defective type of decay accelerating factor, then our own complement system may attack the RBC, resulting in hemolysis. So this is known as paroxysmal nocturnal hemoglobinuria. Paroxysmal means on and off, okay? Nocturnal during the night time, and hemoglobinuria is passage of the hemoglobin in the urine. That is the literal meaning of the term. But this is a very complicated condition. Here, hemolysis is definitely going to occur, there's no doubt. At the same time, there is, suppression of bone marrow, okay? And there is formation of thrombus in different parts of the body. The mechanism, how this thrombus occurs is very, not well understood, but it can give rise to thrombus in different, vein especially, and arteries also. It can also result in stroke by causing thrombus in the cerebral circulation. It can also form thrombus in other parts of the body. Regarding the diagnosis, okay, regarding the diagnosis of this paroxysmal nocturnal hemoglobinuria, we can go for Ham's test. So let me write that for you here. Ham's test. This Ham's test is all about, acid hemolysis test. So we add a diluted type of acid onto the population of RBC, and those RBCs are easily destroyed. This is called positive Ham's test. But this Ham's test is not very commonly done these days. So one specific, another test is also there. This is known as flow cytometry. Okay, this is advanced type of test called flow cytometry, also known as CD55 assay, because this disease is caused by problem in CD55. Okay, so that is the reason. And regarding the treatment, we go for bone marrow transplantation. That is a definitive therapy, but that is not possible in all the patients. So we can go for warfarin therapy to decrease the chance of thrombus formation, and some of the monoclonal antibody, treatment as well. So a little bit information regarding paroxysmal nocturnal hemoglobinuria. Okay, so let's move further. Now, another variety of hemolytic anemia is the extrinsic disorder. That means extracorpuscular abnormality. The problem is not in the RBC. The problem is outside the RBC. That is the meaning of extrinsic abnormality. Now, what are those? The first in the list is antibody mediated. And the good examples are transfusion reaction. Now, remember, in yesterday's surgery class, we talked about blood transfusion, and we talked about mismatched blood transfusion. So if blood grouping and cross matching was not done, and we just simply give the blood transfusion, then this type of reaction can occur. That is the meaning. Now, can you give one example? Which antibody is present in blood group A patient or person? In blood group A, which antibody is present?
B.
B, sir.
Exactly.
Antigen A, antibody B.
Exactly. It is known as anti-B, isn't it? Anti-B, antigen is A, but antibody is B. So if I give a B blood group to that person, there will be severe hemolysis. So this is known as antibody mediated. Very easy to understand. Another is erythroblastosis fetalis. This is RH incompatibility problem. So if, okay, the mother is RH negative, in the first time, probably nothing will happen because there is no mixing of the fetal RBC with maternal circulation. But from the next pregnancy, the mother is ready with the antibody formation against the fetal RBC, and those antibodies can cross the placenta go to the baby, and they can cause severe hemolysis. This condition is known as erythroblastosis fetalis. Okay, we'll talk about this in the discussion of obstetrics. Another example of antibody-mediated problems are idiopathic, we don't know the cause, drug-associated, systemic lupus erythematosus or SLE, and even mycoplasma infection. This is a type of bacteria, atypical bacteria. So these are also causing antibody-mediated damage of the RBC. Second heading here, okay, so let me underline this important thing for you, are the mechanical trauma to red cell. And these are microangiopathic hemolytic anemia. This is a very important concept, so please listen properly here. Microangiopathic means a small size blood vessel. Now, these all situations cause narrowing of the blood vessel in certain organ, okay, by causing thrombus. Now, when RBC passes through those small capillaries which are already narrow, there is some damage done to the surface of the RBC. Now they become defective RBC, and our immune system will remove those defective RBC from the circulation or destroy them. Okay, this is known as microangiopathic hemolytic anemia. Now, if somebody asks you, what are the different types of microangiopathic hemolytic anemia? Look at the type now. Thrombotic, thrombocytopenic purpura. This is known as TTP. Okay, TTP. Disseminated intravascular coagulation, DIC. Hemolytic uremic syndrome, or HUS. These are the classical causes of microangiopathic hemolytic anemia. On the other hand, if somebody, okay, has replaced the heart valve, if they are having the artificial heart valve, so when RBC are passing through those heart valve, then also there will be traumatic type of hemolytic anemia. We call it cardiac traumatic hemolytic anemia. Okay, so these are the very important questions in the exam. Infections like malaria can also result in hemolysis. Malaria, in fact, is an important cause of hemolysis because the life cycle of the parasite which causes malaria, causes Plasmodium, you know, it is inside the RBC. So it will damage those RBC and cause hemolysis. Lead poisoning can also lead to hemolysis by chemical injury to the RBC. And one of the very important mechanism is hypersplenism. Hypersplenism, that means spleen is overfunctional. Spleen is big and overfunctional. So it will consume even the normal RBC there and destroy them. This is known as hypersplenism. This is the mechanism. The RBCs are sequestered in mononuclear phagocytic system, especially inside the spleen. Mononuclear phagocyte means, okay, they are the, what is the another name for them? This mononuclear phagocyte, yes? Quickly, quick answer. Which cell? Monocyte, okay? They are the monocyte or macrophages. Monocyte or macrophages. Because they have single cell. That was the term mononuclear, and they are the phagocytic cell. So in other words, the RBCs are hidden inside the spleen and they got destroyed there. This is known as hypersplenism. Now, the third important mechanism by which anemia results is impaired red cell production from the bone marrow. What are the mechanisms there? Let's talk about it. Disturbance of proliferation and differentiation of the stem cells is one of the mechanisms. See there? Disturbance of proliferation and differentiation of the stem cells. What does that mean? So let me clarify that. Aplastic anemia, pure red cell aplasia, anemia of renal failure, and anemia of endocrine disorders. Out of them, the top two are the very, very important one to understand. Aplastic anemia means the hematopoietic stem cell, which is present there, especially the myeloid stem cell, is, okay, aplastic, means it is not present there. So all the myeloid series of the cells which are developing from there are absent or severely decreased in number. If they are decreased in number, we call it hypoplastic anemia. If they are deficient, we call it aplastic anemia. So what is the problem here? There is pancytopenia. All three different type of cells are decreased. RBCs are decreased, WBCs are decreased, and platelets are decreased. In the WBC, neutrophils are decreased, not the lymphocyte. Remember this. So pure red cell aplasia is another one where only the RBC precursors are absent. Only the RBC precursors. Okay. So this is also known as diamond black fan anemia. We'll talk about this a little bit later. Another is anemia of renal failure because the effect of the toxins. Okay, the bone marrow will not function properly, and anemia of endocrine disorders like hypothyroidism can also result in anemia. Another is disturbance of proliferation and maturation of the erythroblast. Proliferation means multiplication, maturation you already know. So this occurs in defective DNA synthesis, result by vitamin B12 and folic acid deficiency. We call that megaloblastic anemia. Megaloblastic anemia. What is the meaning of megaloblast?
Cell increase in size.
Macrocytic,
Is
large size.
then MCV.
A large abnormally developed cell.
Exactly. Megalo means big. Now, blast means very immature cell. So that's why I want to clarify it here. Megaloblast and macrocyte are not the same term. Megaloblast are the very immature cells which are present in bone marrow. But macrocyte are the mature cell present in peripheral circulation. Okay, both of these are big in size, there's no doubt. But to see the megaloblast, you need to do bone marrow aspiration or bone marrow biopsy and analyze that under the microscope. These are megaloblasts. And they are seen in vitamin B12 and folic acid deficiency. Now, another is defective hemoglobin synthesis, which occurs in iron deficiency anemia and thalassemia. In iron deficiency anemia, there is deficient heme synthesis, whereas in thalassemia, there is deficient globin synthesis. Now, third mechanism of impaired red cell production is unknown or multiple mechanisms involved, like sideroblastic anemia, anemia of chronic infection, and marrow infiltration. So let me explain this a little bit here. This sideroblastic anemia is a very interesting condition where iron is there. Iron is there in excessive amount actually, but that iron cannot be utilized, okay, to synthesize the RBC. Rather than the normal RBC, these RBCs are having ring sideroblast. Ring sideroblast. That means, okay, that means those iron are collected inside the mitochondria, and those mitochondria will encircle the nucleus of that RBC, which is known as ring sideroblast. Now listen properly here. The mature RBC doesn't have any nucleus. So this has to be the premature type of RBC, which are still present inside the bone marrow. When RBC comes out of the bone marrow, remember they are the mature one. They don't have any nucleus now. But the immature or the early RBC precursor, they are having nucleus. So sideroblastic anemia affect those type of RBC or immature or premature RBC present in the bone marrow. And the hallmark is a picture of ring sideroblast there. It may be hereditary or it may be acquired. It may be present in some of the malignancy. It may be present in case of lead poisoning and those type of situation. Okay, so we'll talk about this again later on when I start the discussion of microcytic hypochromic anemia. Another is anemia of chronic infection. Any chronic infection in our body, like tuberculosis, okay, any connective tissue disease, like they are the inflammation actually. So this is seen in both inflammatory and infective condition. So you can take that example as well. Lung abscess is a type of chronic infection, isn't it? Bronchiectasis is a type of chronic infection. So in all of this situation, the person will have anemia of chronic disease. Okay, anemia of chronic disease. The last one is a marrow infiltration. Now, infiltration means it is associated with cancer. This is metastasis of malignant cell into the bone marrow. Now remember, in stage 4 malignancy, most of the malignant cells will reach the bone marrow and they destroy the bone marrow, resulting in pancytopenia. So this is the mechanism. Now, this is a bit of complicated type of classification we discussed. So I want my student to revise this, this concept and make it quite clear. It's a very important concept. Now, let me talk about another easy type of classification than this. And this classification is based on color and size of the RBC. Now, based on the color, we have normochromic and hypochromic anemia. So normochromic and hypochromic. Now, one question should come in your mind. If the color is still normal, then how the patient becomes anemic? Yes? How? How the person become anemic now? Who can answer this?
Sir, the size is different.
Okay. Any other? I got your point. Any other student? My question is very easy here. Color is.
Sir, may I ask?
Yes, sure. Sure, Uzair.
Sir, basically, sir, we have the adequate amount of hemoglobin, but sir, basically, sir, we have the less number of red blood cell in normochromic anemia. That's why, sir, we will be hypoxia.
Very good answer. Very good. So that is the explanation here. Now remember, in the definition of anemia, I clearly stated there, it is not always the concentration of hemoglobin. It is also because of the decreased number of RBC. So still hemoglobin is normal here in individual RBC, but if the total number of RBC itself is decreased, definitely there will be anemia. So this is known as normochromic anemia. Okay, now see that? That means the central pallor of about a third of the diameter of the RBC, which is normal, is still present here. Whereas hypochromic anemia is decreased color, and that is seen as an increased central pallor of the RBC more than the third diameter. If central pallor is more, this is hypochromic anemia. If central pallor is still normal, but the number of RBCs are less, this is normochromic anemia. Now, another one is based on the size of RBC. We have microcytic anemia, normocytic anemia, and macrocytic anemia. This depends on the MCV. If MCV is less than 80 femtoliter microcytic, if it is between 80 to 100 normocytic, if it is more than 100, we call it macrocytic. Now the different examples of these are written in the next slide. You see that? Classification of anemia based on the morphology of the red cell. Okay, morphology means how they look. How they look. Morphology is all about that shape, size, and the color also. Now, microcytic hypochromic anemia is the first one. Now, iron deficiency anemia is the most common type of anemia in clinical practice. Okay, so this is microcytic hypochromic in nature. Another is thalassemia and lead poisoning, and we classify them under ineffective erythropoiesis. Now, let me clarify this for you. Erythropoiesis is a mechanism of RBC synthesis. Ineffective means that process is a faulty one. Okay, it is not very effective. So what does that mean? Immediately after those RBCs are formed, they are destroyed right there inside the bone marrow. This mechanism is known as ineffective erythropoiesis. They cannot even come to the peripheral circulation. So the disease which damages RBC by this mechanism are thalassemia and lead poisoning. Lead is a type of heavy metal, okay? So it can cause a lot of symptoms and sign in our body. Neuropathy is very common in lead poisoning. Abdominal pain is very common in children. At the same time, it can result in anemia. Now, third important cause of microcytic hypochromic anemia is sideroblastic anemia. We just talked about this a little bit. This sideroblastic anemia is the presence of ring sideroblast in the bone marrow. So we need to do bone marrow aspiration or biopsy to diagnose it. That's the first thing. It can be hereditary, it can be acquired. Sometimes these ring sideroblasts are associated with malignant condition, myelodysplastic features, and sometimes even lead poisoning can result in sideroblastic anemia. In sideroblastic anemia, the level of iron is enough in the body. Actually, it is more than enough, but that iron cannot be utilized for the synthesis of hemoglobin. Okay, and regarding the treatment of sideroblastic anemia, we can go for blood transfusion, and sometimes vitamin B6 therapy may help the patient. Another is anemia of chronic disease. In any chronic infection or inflammation in the body, after certain duration, the person will become anemic because of this mechanism. In this also, the iron in our body cannot be utilized for the formation of hemoglobin. That is the basic problem. Okay, let's move on. Now, just have a look here. Look at this slide. This is the normal peripheral smear, and just compare this normal peripheral smear with this one. What can you see here? Yes? What can you see here? See there in the slide? Anyone?
That decrease RBC size and
This
less.
is irregular in the first one, like
And
quite
The nucleus is large.
So we have already picked it. The sizes, okay, of the RBCs are slightly decreased, but this is a magnified view, you know. This is a bit of minimized view. So it looks like these RBCs are still looks a little bit bigger, but actually speaking, if I convert this also the same size of the topper one, then the RBCs are smaller in size here. That's why they are called microcyte. An important point is a hypochromic. Look at the central pallor of these RBC. The central pallor is more than 1/3. That's why they are known as hypochromic RBC. So these are the features of iron deficiency anemia, and these are the lymphocyte presence here. Okay, both of these are lymphocyte. Now, what about the normocytic normochromic anemia now? See this? Normocytic normochromic anemia. The size is also within the normal limit, and there is adequate amount of hemoglobin there, but the problem is the number of RBCs are reduced. That's why this patient is having anemia. So the examples of these are, there is impaired cell production with decreased reticulocyte count. Now the question is, what is reticulocyte? Yes, what is reticulocyte?
Mature RBC, sir.
Mature RBC. Yes. Any other answer? Any other student?
Sir, it was said in the first time they will have ribosome in their cytoplasm, but when they lose their ribosome, then it becomes mature.
Good, good. So many students are answering. That means they are quite confident. Okay. So that's what the teacher takes. See here, if you speak with the confidence, then you know the thing. You just remember one small point here. This is one stage prior to mature RBC. Just one stage prior to the mature RBC. Within 1 to 2 days, reticulocyte will convert into mature RBC. So now what the point I like to highlight here is, if there is decreased reticulocyte count, that means RBC is not properly synthesized by bone marrow. Okay, and these are the situation. Physiological anemia of infancy and pure red cell aplasia. In this condition, there is decreased reticulocyte count, whereas they have normal leukocyte count and normal platelet count. Only the RBC series is affected. Some other situation, there is pancytopenia. There is reduced leukocyte count, reduced platelet count, and reduced reticulocyte or RBC count. These are seen in aplastic anemia and leukemia. Now, look at the difference here. In pure red cell aplasia, there is only problem in RBC. WBCs and platelets are normal. Whereas in aplastic anemia and leukemia, these are called pancytopenia. All three cell lines are going down. Both of them are having decreased reticulocyte count. Another very, very important example of normocytic normochromic anemia is hemolytic anemia. Not all, there are some exceptions here, okay? But majority of the hemolytic anemia belong to normocytic normochromic anemia. And hemolytic anemia has one important hallmark, that is they have increased reticulocyte count. What is the mechanism? So listen here, this increased reticulocyte count is the response of overfunctioning of bone marrow. In hemolytic anemia, because of lysis or destruction of the RBC, there is tissue hypoxia. Because of tissue hypoxia, there is erythropoietin release. That erythropoietin will act on the bone marrow, and bone marrow is trying to synthesize adequate number of RBC. That's why if you take bone marrow biopsy or aspiration in hemolytic anemia, there is erythroid hyperplasia. Erythroid hyperplasia. What does that mean? The erythroid series is increase in number there. Then one question will definitely come to your mind now. If bone marrow is synthesizing a lot of RBC, then why the patient suffers from anemia? Isn't it? That question should come in your mind as a beginner. Answer is very easy. The rate of destruction is more than the rate of synthesis. That's why hemolytic anemia occurs. Yes, the bone marrow is trying to synthesize RBC, but that rate of synthesis cannot catch the rate of destruction. So hemolysis still leads to anemia. The good example are G6PD deficiency. See here, let me highlight, underline them. G6PD deficiency, RH or ABO incompatibility, and malaria. Even hereditary spherocytosis, sickle cell disease, okay, autoimmune hemolytic anemia, you can add here. These are other examples. But thalassemia is an exception of hemolytic anemia, which is having microcytic hypochromic cells rather than normocytic normochromic cells. Remember that as an exception. Thalassemia is an important type of hemolytic anemia, but that hemolytic anemia doesn't have normocytic normochromic cell. Let's move on. The last part is a macrocytic anemia. Macrocytic means bigger number of cells, a size of cells, bigger size of the cell. Macrocyte means if I measure the MCV, it will be more than 100 femtoliter. So they are again divided into megaloblastic anemia and non-megaloblastic anemia. A megaloblast means the premature type of RBC present inside the bone marrow are bigger in size. And the classical causes are vitamin B12 deficiency and folic acid deficiency. Every student know that. Whereas non-megaloblastic macrocytic anemia are caused by Diamond-Blackfan anemia and congenital dyserythropoietic anemia. Now a bit of difficult terms for you, so let me explain them. Diamond-Blackfan anemia, okay, is again a type of hereditary condition. So this is autosomal dominant disorder. Autosomal dominant disorder. So it runs in the family, and there is a 50% chance of occurrence in every pregnancy. In this condition, there is only problem regarding the red cell precursor. Only red cell precursors are affected. So it is also known as pure red cell aplasia. Pure red cell aplasia. This is a very good term to remember. Pure red cell means only red cell series are affected. Aplasia means they are not synthesized at all from the bone marrow. So what will happen to the patient now if there are no red cell production? Yes? Or if there are very decreased number of red cell formation, what happens? The patient will have severe anemia. Isn't it? Very easy. Severe anemia. And this is known as diamond blackfan anemia. So whatever precursor or premature cells are there, they, they are present inside the bone marrow. But the mature type of RBCs are not formed properly. Now, apart from that, these child are also having multiple congenital anomaly. Okay, multiple congenital anomaly in their body. Those congenital anomaly may be the thumb anomaly, which is very common. Thumb anomaly, as well as craniofacial anomaly. The problem in the cranial bones and in the face. Now, how many phalanges we have got in our thumb? How many phalanges are there in the thumb?
14.
No, thumb, only thumb. Thumb.
Two.
Not in the hand, okay? Thumb. See this. 2, isn't it? The answer is 2. In other finger, we have got 3, but in thumb, we have got only 2. Now listen properly. In case of diamond blackfan anemia, if you closely examine the child may be having only one phalanx. The another phalanx may be absent. This is known as short thumb. This is a very important finding you can pick. If you are in doubt, you can always take the X-ray. X-ray will clarify the situation. So this is diamond blackfan anemia, and the treatment of diamond blackfan anemia is corticosteroid. Okay, and diagnosis is done by bone marrow aspiration. Whereas congenital dyserythropoietic anemia is another congenital situation where RBCs are not synthesized properly in the bone marrow. Now look at this peripheral smear. What can you see here? All of you please focus there, okay? See there, please. Now what is this? What type of cells are they? See, these cells look definitely bigger. Okay, these cells look definitely bigger, and they're having more color. These are having more color. I cannot see any pallor there at the center.
Hyperchromic.
Now,
hyperchromic.
Very good. So these are hyperchromic. And look at this. This is what I want to show you. Can you count how many segments are present in this neutrophil? Just count here.
Hypersegmented.
Exactly.
Hypersegmented.
Definitely more than 5, right? So see there, 1, 2, 3, 4, 5, 6. If you count this also, it will be 7. Definitely more than 5. So this is hypersegmented neutrophil. This is a very important finding of megaloblastic anemia. So see there. So this will, clear your doubt if you have any. Let's make this as a last slide, but this is an absolutely important one. So I want every student to pay attention here when I'm describing it. This is how, okay, you classify anemia. This is like a summary. So first is, okay, the definition. And for that, I need to check the hemoglobin. In male, if it is less than 13.5, and in female, if it is less than 12, we call it anemia. You already know that. In children, the lower value is less than 11. After that, we check MCV, mean corpuscular volume, just to classify this under microcytic anemia normocytic anemia or macrocytic anemia. If MCV is less than 80 femtoliter, microcytic. If it is between 80 to 100, normocytic. If it is more than 100 femtoliter, macrocytic. And these are the different type. Iron deficiency anemia, thalassemia, anemia of chronic disease, and sideroblastic anemia. I want to add one more, lead poisoning here as the example or the causes of microcytic hypochromic anemia. Usually they are associated with hypochromic RBC also. Whereas normocytic, okay, we look for reticulocyte count now. If reticulocyte count are low, that means bone marrow is not functioning properly. Bone marrow is not synthesizing the cells properly. That's why the retics count are low. And the common causes are marrow failure, aplastic anemia, myelofibrosis. This is fibrotic reaction of the bone marrow, leukemia or metastatic damage of the bone marrow, renal failure is suppression of the bone marrow, and anemia of chronic disease. Okay, so it also leads to normocytic type of anemia, but more commonly it leads to microcytic anemia. See here in both column it is written here. Whereas if reticulocyte count is high, this is clear-cut case of hemolysis. Hemolysis. Now look at the example. All of these are hemolytic condition. Sickle cell anemia, G6PD deficiency. Okay, this is G6PD deficiency. Hereditary spherocytosis, autoimmune hemolytic anemia, and paroxysmal nocturnal hemoglobinuria. These are having high reticulocyte count. These are hemolytic conditions. And the last one is macrocytic anemia, megaloblastic anemia caused by B12 and folic acid deficiency, as well as alcoholic liver disease, and one more, hypothyroidism. All of these results in macrocytic anemia.